Charlton Murray, also with the BHF.
Thank you.
I'm Shelin Tlapo from the HFMU.
Yes.
Thank you. Connie Buckus, I'm from the HFMU.
Eric Ranso, Shared Services.
Michelle Bienica from the BHF.
All right. So is it Mr. Mutuli or Dr. Mutuli? All right. So Dr. Mutuli, let's take your oath at this point, because my understanding is you will be leading the presentation for BHF.
Yes.
All right. Will you then take, what do you prefer, an oath or an affirmation?
The oath is fine.
All right. So will you say after me, I, and then announce your name?
I, Katlego Mutudi,
Swear that the evidence that I shall give
swear that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth.
the whole truth,
Raise your right hand and say, so help me God.
so help me God.
Thank you. So when you are ready, you can get started.
Thank you very much, Chair. Our submission, which I will read from in the later part of the discussion, was centered largely around two areas, which we deem to be of interest to this inquiry. The first point is around the practice code numbering system, and then the second element is around the health forensic management unit. But we thought, as we were sitting from yesterday here, there are just some additional comments that we should make that we have packaged into the presentation. You do not have the slides, but we will submit them to you. They were not part of the original submission. Secondly, we were advised that it would be advisable to lump the BHF and HFMU presentations together. So Dr. Nhlapho will later on talk about the HFMU specific details.
All right. Well,
And,
maybe at this point, then, if Dr. Nhlapho will be speaking, let me just take his oath so that we don't have to do it before he speaks. Dr. Nhlapho, will you just say after me, I, and then your name?
I, Shelin Tlapo,
Swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and then raise your right hand and say, so help me God.
so help me God.
Thank you. Yes, Dr. Mutuli.
Yeah, can I maybe also advise that at least Mr. Muruve and Ms. Buckus will be joining in the presentation. I don't know if it would be convenient maybe to swear them
Yes,
in.
it will be. I just want to make sure that everyone who speaks does so under oath, so
Yeah.
that later on there can be consequences. Sorry, what's your name?
Charlton Murray.
Morule.
Murray.
Okay. So, Mr. Morule, will you then say after me, I, and then your name?
I, Charlton Murray,
Swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and then raise your right hand and say, so help me God.
so help me God.
And then, is it Miss Biokas? Bacchus. All right, will you then say after me, I, and then your name?
I, Connie Buckus,
I swear that the evidence that I shall give
swear that the evidence that I shall give
shall be the truth,
shall be the truth,
the whole truth.
the whole truth,
Raise your right hand and say, so help me God.
so help me God.
Thank you very much. Yes, Dr. Mutuli.
Thank you, Chair. This is the shopping list for our discussions this afternoon. We gleaned some of them from the discussions emanating from yesterday and even today. Just maybe to bring perspectives from our side on some of the general discussions. So we'll go through some of the definitions and then some key points from yesterday, and then we'll go through our submissions, and then just to conclude on our experience on the complexities of investigations. So I think just to introduce ourselves, BHF is a member association voluntary organization which is not for profit for healthcare funders. We largely represent medical aid schemes, administrators, as well as managed care organizations from South Africa and 7 other Southern African countries, largely in the South African development community. What we do, as an industry body, we represent members' interests. So we articulate issues of pertaining to healthcare policy through lobbying and advocacy. So we will offer review of maybe regulatory matters that are pertinent to the operations of the organizations that we represent. We also look at trends in the industry, this with a view of advising our members to make sure that they refine their practices to events. We also look at engagements. We very active in terms of education and training. There's a large part of thought leadership that we play in to enhance skills and knowledge. By so doing, we're guiding our members through these processes. There's a bit of more detail in this slide that you can have a look at. The reason that we are part of this process, as I have articulated, we do have a vested interest as a BHF. Being in the medical aid industry and also being cognizant of the nature of the industry, we are guided largely by what the Act prescribes, because that's what our members are guided by. So issues that are discussed this morning around Section 59 of the Act, Section 66 and other relevant parts of the Act that talk to claims processing and benefit assessment, would thus form a large part of what we are interested in. But of significance are the losses that are made by schemes through the claims processes. To this end, there is that focus which we have participated in through the HFMU. Our view on fraud, waste and abuse is that this is an industry issue. We advocate for a non-competitive outlook, that there should rather be collaboration among all the stakeholders, because it's a common problem. It does affect various entities in varying manners, but it is an industry issue. As a result, BHF has for a while acted as a repository for data, and we have been a player who does not have vested interest in that. We do not administer any claims or participate in administration of any benefits to members. We are cognizant of the fact that it's a very complicated environment, and I think some of the slides later on will go into detail. So there's quite a number of stakeholders that are involved in this. If you're looking at from a patient's perspective, Dr. Kawane earlier talked about the triangle that involves the member on one hand, the funder and the practitioner, with the links not being as straightforward as they should be. But the patient is directly linked to the medical aid. There are other players. You've got the regulators, switching companies that facilitate claims payments, and other people that look at management of the benefits, including managed care entities. From the healthcare service provider side, they are also regulated, but there are many disciplines as well, whether you're talking from the supply side of devices, technologies, other secondary providers like pathology and radiology, pharmacy, etc. And overseeing this are your regulators, but we also have involvement of law enforcement and professional bodies. I think somewhere in our submission we talk about some of the formalized collaborations that we have tried to seek in the last year or two with bodies like the SIU, the NPA, etc. Because we do realize that it's not just an issue that the industry can handle to finality on its own. So it's really a very involved and complicated environment, just focusing on fraud, waste, and abuse. I think to articulate this, and there's been quite a number of questions around definitions like what is relevant and what are the roles of the various players. I think it's important for us to go back to defining what the business of a medical scheme is. In as much as there's this transactional nature between the various entities, members pay contributions, there are claims processes when they seek healthcare services. The main thing is that the scheme defray costs for the scheme, for the beneficiary in exchange of a particular contribution. But the main thing is around the relevance of the healthcare service. And in this, we would include one of the components as being the affordability component, that in terms of adjudicating what relevance is, the issue of cost should never be far away. The issue of best practice should also be considered when you're looking at the relevance of the programs that are deployed in this. One of the responsibilities of the administrators, usually articulated in the contracting process, is that they must make sure that all the claims that are paid for by the schemes are validated. Now, the process of validation is quite involved. It starts from even saying, is the member the correct one that is registered? Secondly, are they the correct one when they are seeking healthcare services? And then there are other back office elements that I touch on, issues involving coding. There was a bit of talk, I've got a slide on that, which is part of that validation process to make sure that the service that is paid for is actually a relevant healthcare service. There was also a question earlier around what fraud, waste, and abuse are. And I think at the time when the Act was contemplated, some of these elements were not clearly defined. But I think over the last decade or two, we've had a bit of clarification on what they are. Now, if you look at this slide in terms of the intent to deceive, I think it was correctly articulated. Fraud is illegal, is a criminal offense, and there is intention to misrepresent facts at a prejudice of one party. Now, when you look at its relationship to waste and abuse, the intention to deceive actually decreases when you move from fraud and you go upwards to waste. In terms of what abuse is, we generally define it as inconsistency with best practice. So when you have inconsistent delivery of services which departs from sound medical practice, that is deemed to be abuse. I will have some examples that I will share with you. In terms of abuse, I think the waste, the key word there is excessive. There is overutilization of services. So there is no misrepresentation, but there might be addition of unnecessary elements of healthcare that are included in the transaction or contact, and that is deemed to be wasteful. Some of the examples, and I think Connie in her presentation will touch on some of these examples. So if we look at fraud, for example, you could have double billing for the same patient. Or a recent example that we looked at is there are healthcare practitioners who would have their own practice number for a solace practice, and they're also part of a group. I consult, and they put a claim not just on their SOLAS practice number, but also on the group. Now they are misrepresenting the facts. There could be false claims. So a member did not attend to the physician, but they sent in a claim. One other method, which is very common now, card farming, where they send somebody out with a backpack carrying a lot of cash, collecting names and membership numbers. They pay out the money, and then they submit this as if those people that they collected the cards from actually consulted. And then we've got also the issue of cash loans, where somebody comes into a practice and say, I need a certain amount of money, and then they submit a claim as if they attended to them for medical consultation in exchange for cash. And as you can see, those are blatant methods where there is misrepresentation of the facts. The other ones, which I think sometimes there is a bit of difficulty in terms of interpreting where they lie. And we found that the abuse and wasteful component probably form the majority of these unnecessary claims. Examples are you are billing for unnecessary services. As I said, you could be having a real consultation, but then your consultation evolves into other areas that are inconsistent with best practice. For example, a person complains of a particular ailment, but without any reasonable argument, you then include other things that you are not really screening for or should not form part of the consultation. The other one is inappropriate use of coding, and there are two examples here where you have unbundling of codes. Now, the unbundling of codes is when there is a definition in the coding manual of a particular procedure. Let's say it's repair of a shoulder, of a frozen shoulder, for example. There would be a particular code. But you know that in the course of you attending to that person, there are many other steps that you would engage in to achieve your process. And then you bill for each of those little steps, which cumulatively then give you more money when you claim than if you just use that one appropriate code. Or upcoding when you are doing a minor procedure, but you know that it would not pay you as much as it would be, and then you use another code that is similar, but not of a procedure that you conducted. Other one is around waste. For example, unnecessary admissions. Maybe a common example is somebody's benefits could have run out, but you want to run a number of tests, but they still have their in-hospital benefits intact. You admit them unnecessarily for the benefit of running those tests. The person needs the tests, but you are incurring other costs that shouldn't have been had you been more careful. There are issues around doing procedures for convenience. If you are an obstetrician, for example, you've got a high patient load, you don't want to be woken up on a Saturday night. It's easiest for you to plan cesarean sections and do on a particular day rather than allowing a person to go into natural labor. That saves you time, but it's a bit more expensive because it involves longer hospitalization and other procedures that you might not have necessarily needed to engage in. Now, in terms of the approach to fraud, waste and abuse, as an industry, as entities, I think it's important to look at interventions just like you would in any risk mitigation. So we believe that as part of your governance framework, fraud management should actually be developed into those processes. And we've just given here a framework that many people deploy to fight this scourge. So you would have policies that talk towards fraud prevention. There are monitoring elements, there's investigation, there's prosecution, and all of this you want them to lead to deterring perpetrators to to committing fraud. The elements that are required, as we've said, are around collaboration. We should not look at it as area for competition, or that's our approach. So there's a lot of information sharing, data sharing, and Shelton will talk a bit about that in terms of the joint action. So if you remember the 3 slides ago, I showed you the various players. You can see how they actually fit in. The role of the BHF is really around fraud detection. We do assist the various entities to strengthen their policies in terms of monitoring and prevention, but we are not involved in the actual investigation. We leave that to the entities that participate in the HFMU structure. In terms of coding, I think we do recognize that this is a highly technical area, but it's central to the work that you do in terms of fraud management. In as much as there are many methods, from a healthcare practitioner perspective, in the South African context, there are probably maybe 3 coding systems that they should be familiar with. And let me deal with those first before I spend time on the slide. The first one is the ICD-10 code. The ICD-10 code is really just a diagnostic. In fact, we will soon be moving into ICD-11 coding, and all it is, it's just a diagnostic method, and it is written into the Act. It is a requirement that when you submit a claim, it must be accompanied by a relevant ICD-10 code. The second code that practitioners use or are confronted with are those that are contained in the RPL. There was a bit of discussion around it yesterday. The custodian of the other coding system, which is used popularly in South Africa, is the South African Medical Association. They do have codes very similar to what is contained in the RPL, but they've got more codes. The definitions are very similar. There are some differences, but not to a large extent. And these are procedure codes. So when you consult, that consultation will have a particular number that dictates what the code is. If you apply or give an injection or anything else, whether you have to suture a laceration, there will be a code that is linked to that. These codes are divided by discipline, so you will have dental codes, you'll have codes for physiotherapists, etc. And the other significant thing is that even within those different disciplines that use similar codes, you might find that there will be different monetary values attached to the code. So a specialist, for example, will still use code 0190 for consultation, but the quantum would be slightly higher. And that is determined by what they call relative value units, which takes into consideration the scope as well as the complexity of the work related to the qualification. So that will be the procedure codes. The US have got a similar system called the CPT coding, and this is owned by the American Medical Association, and they have got 3 categories. The one that is similar to the RPL is category 1 that talks to procedures, etc. And the last one, which we did not include here, are the NAPI codes, and then the ATC classes, mostly for medicines and material. And from a healthcare provider perspective, those are the ones that they would use. When you look at the administrators and other suppliers, hospitals, they will use a lot more the CPT codes, and they also develop a lot of in-house codes depending on their reimbursement models, etc. But I don't want to complicate the discussion because it's not that relevant to the discussions. So when you look at how coding is central to fraud, waste, and abuse, and also to validation of claims, it is important that when somebody submits a claim, the various codes actually talk to one another. When you've got a diagnostic code that says this person has got an abscess, the procedural codes that are attached to that claim must actually talk to the diagnosis. And that's part of the validation that if a scheme, for example, receives a claim that says abscess, but the codes do not talk to that, that might necessitate the scheme or administrator reaching out to the provider and say, justify what you said, or it might be even rejected offhand. So it's quite complex, but I think in our environment there are specific codes that the industry uses, and I think there is consistency in that regard.
Dr. Mtuli, may I ask you, you mentioned in passing, and you didn't go into detail, but you said that some of the schemes that produce their own in-house codes. Did I hear you correctly?
Yes.
I suppose my question is there amongst your members consensus across the board in relation to what procedure code should be used for particular procedures? And I ask the question because so far the evidence we've heard suggests that there are numerous codes, and you seem to be confirming that to the extent that you say schemes are producing their own in-house codes. So perhaps you could just clarify that.
So to the extent that there is involvement with external stakeholders, they would at least be guided by the contractual arrangements with the stakeholders. Let me give an example. If, for example, one administrator has an alternative reinvestment mechanism with a hospital group, for example, in the contract, they would then agree to the reinvestment model, and they'll also agree to what codes form part of their agreement. If you are going to bundle, let's say, certain procedures, and there's one, let me give an example of a group that uses, let's say, hip and joint procedures as part of bundle payments. In the contract, they would say these particular procedures, we would reinvest them at this rate, and this is included. These codes are included in this arrangement, and then we carve out these either based on the value or time and other requirements in terms of the agreement. But in terms of the industry, as I said, there is a general usage of RPL. In the back office, they do use the CPT codes. In as much as there is no industry standard on or guidance on how to use this, there is general usage of a certain number of codes.
So the example you gave in relation to the hip and joint alternative reimbursement mechanism is interesting, but it does seem to suggest that it's quite unique to reach agreement as to which codes should be used, because it relates to specific procedures, as I understand it. But what I'm really trying to understand, and it's the second answer that you gave, or second part of your answer, is the RPL we heard yesterday has been declared invalid, but it's still in use. The schemes seem to have developed their own procedural codes. We're told there's a SAMA code which mirrors the RPL somewhat and other ways not. I'm just trying to understand from a provider perspective. We heard evidence yesterday where providers had their codes challenged. How would they know which code to use with such diversity in this kind of environment?
So I think the challenge around RPL were articulated yesterday around the anti-competitive nature from bargaining perspective. What has happened since is that obviously each scheme implements its own tariff file, and the majority of these tariff files will be based on loosely on RPL. A number of the professional societies, whether you are the South African Society of Anesthetists or optometrists, they would then also issue their file to their members. Some of the societies have got formal relationships with the schemes, and they would enter those into the scheme's tariff file if there is such relationship. So from those healthcare practitioners that are organized into societies, there would be an industry standard that would come from the society's part. In terms of them being adopted by the schemes, there's usually engagement at a scheme level. But if you examine the various tariff files of the different schemes, there isn't that much of a difference in terms of the codes that are contained in there. The major difference, I think, from around 2009 has been around the cost or the price attached to each tariff file. But even having said that, you find that it could be no more than 10 to 15% difference, except when you have specific reimbursement arrangements that are based on networks or DSP arrangements.
Would you say that, from what I'm hearing you saying, is that there's not that much of a difference between the schemes and there are industry standards? But would you agree with, for example, the submission by the Competition Commission that there needs to be a uniform coding system? Or do you think that's just unnecessary?
Yeah, we agree that there should be a uniform coding system. It would definitely reduce the complexity and fragmentation.
You just tell me, I mean, where are the problems concentrated? In fraud, in abuse, in incorrect coding? What is the impact of this improper usage of codes?
So it would be difficult to say in terms of each element that I've mentioned what the contribution is. Largely, we estimate, and I think Dr. Kawani made the same submission this morning, that we estimate the impact of fraud to be as much as 15% of your claims exposure, total claims exposure. Now, to the extent that the three elements, we still think that the majority fraud forms maybe a smaller part in comparison with the other two. Yes. So the challenge is really around the waste and abuse, but we lump them together because the processes are similar.
Because you see, in your affidavit, in paragraph 15, you say that fraud, waste, and abuse within the medical schemes environment is significant. It is being estimated that 28 billion, so yours is 6 billion more than the estimate by the CMS, is spent by medical schemes paying claims that amount to fraud, waste, and abuse. Now, the problem, if you look at that, is that you don't actually know how much of it is deliberate, how much of it is just mismanagement by schemes themselves, and how much of it is abuse, in other words, negligence and carelessness, which is the three terms you described. Which is why in the morning I tried to understand how do we distinguish these three terms and how do we account for each of those terms separately. Because when I listen to people this morning, I end up not being sure if the view from the regulator and from the industry is that there is 28 billion rands that gets lost because doctors are misbehaving, or there's 28 billion rands getting lost because the systems are dysfunctional.
Yeah, I think it's an important point, and I think it's important to acknowledge that schemes are different. They would have different capacities in terms of how they manage their processes. There are also different methods brought in by the different administrators. You, in as much as the industry is not very big, you've got, I think, 20-something odd administrators and managed care service providers. Obviously, they would have, as part of their armory, unique propositions. So there's no standardization on the back office applications. However, I think there are certain things that we would all do in terms of validations. Now, we talk about fraud, waste, and abuse as if it's static. It also evolves, because as soon as you switch off one tap, perpetrator find another, just like in any criminal activity. So there is a need for people to be agile and develop. Unless you are a very large administrator and you are able to invest a lot of capital into your methods, you are almost always catching up. In our discussion, some later slides, I'm also looking at the global view. Even countries that are deemed to be a bit more developed than us are still fighting this. Then the quantum of money lost is still staggering. So we have to recognize that the methods used by the perpetrators are also evolving, while we still looking at what is required in terms of the basics. There are newer things that are happening. What we decided as part of the collaborative effort is to make sure that we share information on all these methodologies, so as the industry moves forward.
But I mean, how much of this amount, whether it's 28 billion or 22 billion, how much of that is fraudulent conduct? And how much is carelessness?
Chair, so in all honesty, there is no exact science which can make us reach to that conclusion. It's mostly estimates, even in territories where they have developed complex reporting systems for determining fraud, waste, and abuse. What you end up with is an estimate. Because if it was so easy to determine it, it would be easy to actually get rid of it. But we are left with estimates which are made from sampling and some statistical analysis. So we cannot really give you an exact answer of where things lie.
Now, I mean, even if you work on the estimate, what is your estimate on fraud? Because what I want to distinguish is how much of this is attributable to deliberate conduct by service providers.
So in the US, where they did some extensive studies, they found that it's between 3 and 6%.
3 and 6%.
Yes. And then the rest would be waste and abuse.
Yes. So would you say that that figure of 3 and 6% would also be applicable here?
I have no reason to believe why not.
All right. So out of this 28 billion, we can say that it is as low as 3%, that is 3 to 6%, that is it's a result of deliberate misconduct by service providers.
Yes.
Now, when you talk about abuse and waste, I mean, one of the things that I looked at when you were presenting earlier is that it looks like the causes of the waste are not attributable to medical practitioners. They are also attributable to schemes.
Yeah, so in our discussion of fraud, we acknowledge that it would be unfair to say it's only healthcare practitioners. We do recognize that there's a lot of collusion that happens. There are instances where scheme and administrator employees would be part of the syndicates, maybe even trustees, for example, or even boards. So it is not just practitioners, and one of the elements that makes management challenging is because of the collusion. So there will be collusion between members, beneficiaries, and practitioners, collusion between practitioners as well as scheme or administrator employees.
Yes, and what have you found is the contribution of the schemes?
I think that as well, we cannot give an outright estimate.
All right, thank you. You can continue.
So can I just follow up on that to say, if that's your estimate of fraud in relation as a percentage or proportion of fraud, waste, and abuse, where does the racial profiling sit in your understanding of what happens? So, for example, let me just be a bit more precise. You provide a platform for sharing information and systems in order to validate claims and to pick up FWA behavior. What have your findings in relation to racial profiling been?
So, I mean, to the extent of our knowledge and belief, the from our side, we do not have any evidence of that. In fact, our submission with regards to the two elements that I alluded to in terms of managing the practice code numbering system. One, there is no capturing of information that denotes race or anything that can be used for that kind of profiling. And secondly, in terms of the data sharing arrangements, there is no provision for race or demographics.
So, but could there be a proxy used? So it wouldn't be outwardly a factor of race or information in which race and that particular demographic information is requested, but where geography or names are available or are known.
There would be pure
in the investigation process.
Yeah, there would be pure conjecture on my part. Whether people would be able to use names, I don't think that would be a valid assertion on my part. Yeah.
Sorry, what do you mean it will be conjecture? You cannot tell from a name whether someone is black or white?
Some people know.
Can you just tell me something else then? In your own report, which is the attached to a submission, you say that you submit statistics to the CMS on geography. So which means you actually know what the geographic distribution of medical practitioners is throughout the country.
Yes.
Yes. And now you also say you submit names of suspended service providers.
Yes.
So can you not tell from the suspended service providers whether or not the majority is black or white?
I think it would be dangerous, Chair. I mean, if you see a Dr. Jones, does it mean that the doctor is white or black? We cannot.
No, but I'm asking you, if you know the names of all of the suspended doctors, is it not easy to tell whether the majority of the suspended ones are black or white?
I can't answer that positively, sir.
All right, thank you. You can continue.
Okay, so with regards to maybe the suspensions that you are referring to with the practice numbers, this comes as a result of non-compliance issues with regards to either not paying the subscription for that year or for not registering with the relevant authority. So there's no filtering or profiling that. It is just a list of people who did not meet the requirements for registration that year. Okay.
Thank you.
So we've touched a bit on PCNS. I think yesterday there was a comment from the Competition Commission regarding where PCNS is placed. I do go into a bit of detail in the submission around the relationship between PCNS, BHF, and CMS. And also, there is confusion about what the role of the BHF is. And all I wanted to explain here is that our role is purely administrative in terms of registration of providers. There is a prior licensing or accreditation process by the relevant bodies, and we then register them on the PCNS so that they can claim from schemes. The PCNS is a product that is under the auspices of the Council for Medical Schemes, and they had contracted the BHF to run it. There was a question around whether the savings that accrue from FWA interventions are passed on to beneficiaries, and I think the indication was that they are not. I don't know this if we can truthfully say that it never happens. What we can say is that some schemes have demonstrated that in any of their interventions that provide savings, some of the schemes have demonstrated that they can pass them on. One specific example is where a scheme has implemented what they call an efficiency discounted option, or EDO, which becomes a sub-option. And that sub-option, with the same benefits, the only difference is that there's care coordination in terms of the beneficiaries choosing a healthcare practitioner that will be the primary contact. Secondly, agreeing to be part of a network. There are schemes that have reported that they have made a lot of savings. The first manner is of passing the savings is to offer that same benefit option at a lower premium. And I think they've reported, 10 to 15% discount on that sort of option. And we just brought this up to say that the issue of passing on savings cannot be just discarded or lumped into one basket of it not happening in any respect. In terms of prevention, I'm just going to go quickly.
Well, I mean, the point that was made by the Commission is that the premiums are constantly going up, even though we are told that there is so much saving being made from FWA.
Yeah. No, we do acknowledge that. We just wanted to pick on a specific example where there were savings, and there has been proof that they are passed on to members. Yeah. So in terms of prevention, I'm just going to go quickly on this. Obviously, there are elements of education that are required for the beneficiaries. I think the issue of insufficient communication resulting in information asymmetry has been muted. And then also, it's important to have internal controls as part of that broader policy or FWA strategy. And also, I think you've also mentioned around efficiency of the systems that are deployed by the schemes. That is important. There is a bit of detail, but I'll just rush through this. I think they will be addressed again towards the end. Okay. So I think we've already touched on some of the elements. We in our submission we positioned the BHF as an industry body, and also what it does for the members. Paragraph 5 talks about where the practice number is positioned. This is quoted in Regulation 5E of the Medical Schemes Act, that it is a requirement in the submission of claims that the practice number is quoted. I've also talked about the relationship between the CMS and the BHF relating to the practice code numbering system and the contractual arrangements that were entered into in 2003. Maybe to the question around whether there is potential information that can be passed on that has got racial information. We thought we should just give a bit of detail around what the processes around the practice number. So we have included, I think it's referred to in paragraph 11, we've included the form that healthcare practitioners fill in and the information that is captured, and it does not include any reference to race. The practice number comprises a number of digits, and this operates as a unique identifier for the healthcare service provider. And what it refers to, among other things, are the provider's discipline and sub-disciplines, but there is no specific reference to race. The paragraph 13 talks to how we then disseminate information to the schemes and administrators. There is a file that is distributed on a daily basis, which includes the name of all the health service providers that are registered, their practice numbers, whether they are part of a group or they are in a SOLAS practice. And this as well does not contain any racial information. To this extent, we have actually provided a report from an independent audit that was conducted last month when this inquiry was being contemplated, and it's included in the submission for your reading. Yeah. I think I will maybe just before I pause, we have made reference to the global community. The BHF is part of an organization called the Global Healthcare Anti-Fraud Network. And in it, there are a number of organizations participating in various territories. There is a European component that around 2004 got together. They had representation from about 28 European countries that started developing this common standard risk measurement. And they do this on an annual basis. So some of the figures that we mentioned and that Shelton mentions are actually coming from publications from that area. That they say that there is fraud exposure regardless of how resourced you are. At minimum, you have about 3% exposure, but most of us will be around 6%. For those entities that have got no structures or minimal investment, it can be up to about 15%. And this is captured in this. So just some figures. We talk about the 4 billion that we are, sorry, 28 billion that we are exposed to. Reports from the USA around 2011 talk about tens of billions of dollars that are lost due to fraud. The GCAN estimates that globally there's about 260 billion rand exposure to fraud. In the national health system in England, they're estimating losses of about £1 billion lost every year. Unfortunately, we do not have those definite figures for SADC, but the figure is around anything from 3 to 15% of the claims exposure.
Sorry, I just want to continue with understanding this racial profiling issue. My understanding of this report by the internal auditor is it's an attachment to your Appendix 2.
Yes.
Now, if you look at page 10, so you say that, I mean, if you look at the actual information you have, which is demographic, age, frequency, geographic, number of active and deleted service providers per discipline, number of new registrations per providers, number of providers renewing their PCN registration, number of suspended providers, number of providers updating their details, number of group practices. And then you look at your overall conclusion. I know you say that the suspended practice is not related to Section 59%. If you look at your overall conclusion, BHF does not perform racial profiling when HSPs allocated a practice code number, even though we have confirmed that PCNS data does include information related to race, ethnicity, religion, or religion.
I think
This does not, however, stop members from drawing racial conclusions from data provided, for example, using names and surnames. So the information relating to race, ethnicity, and religion is available, and it can be used to draw conclusions based on names and surnames for racial conclusions.
Yeah, I think there is a typo there. It should say does not include. I think we can correct that.
Does not include.
It does not include.
But then the second point, the last line, is still that
exactly.
Conclusions can be drawn from the available data using names and surnames, but you deny that a name and a surname can be used to draw a racial conclusion.
Yeah, I'm saying my personal view, it would be very difficult to do that, but it doesn't stop anybody from drawing assumptions.
And you say here we should insert not when it says the data does include
Does not
information.
include, yes, yeah.
Would you be willing to share the statistical information with us
Yes.
over a period of
Yeah.
time?
Yes.
Great.
And page 12 of the internal audit report again says, even though we've confirmed that PCNS data does include information related, you're saying that too is a
Yes.
typo.
Yeah.
Just on that, sharing that statistical information with us, we will send a letter following up, but just to ask, are you able to disaggregate that information so that it separates out group practices and individual practitioners?
Yes, it's possible.
Can I ask a follow-up? For example, under number of suspended providers, how is your statistical information compiled? Is it just practice numbers? How do you compile that number of suspended providers? Is there a way to look beyond practice numbers? At the names, for example, of the suspended providers?
So the line with the details of the active providers and the suspended providers are exactly the same. The only difference is that there's an indicator that one is suspended and the other is still active. So all the information that you find on an active provider would be available on a suspended provider.
And just to clarify that point, because there's been some talk of suspension today as well. When you speak about suspended providers, what are you talking about?
We mean that they did not renew their practice number. So it's completely different from suspended. What schemes do, they normally use the term blocked to say that this provider is blocked from direct payment. So for ours, it's just that practice number has not been renewed, and we pass on that information to the scheme.
All right, thank you. Who will be the next presenter?
That's me, Chair.
Thank you.
Thank you very much for the opportunity. I think I must just give a background, having been involved in the fraud, waste, and abuse space. A lot has been said, but I want to take us back to where the real issue sits to find ourselves in this particular problem. Medical aid premium, as we know it, that members pay every month to belong to a medical scheme. It remains a crutch purchase. It remains a crutch purchase, and it will be so for the foreseeable future. The issue as well as the issue of entitlement. People pay a premium, and in their minds, this is their money, you know. They forget that this is paid in lieu of medical expenses, especially future ones, because in the medical aid industry, the young and healthy who belong to the medical aid are subsidizing the old and frail. So that's the nature of the beast that we're dealing with. But I mean, the people on the ground don't see it as such. If I've got benefits for 2019, January to December, and I don't use them, come the end of the month, I must make a plan to get as much as I can. Thus, we find ourselves having to deal with the issues of fraud, waste, and abuse. So that's the basis for all the issues and problems that we find ourselves. And I mean, that talks to what needs to happen from us as funders and administrators in terms of member education. I think we should go out there at all times and not stop to educate the members that actually a medical aid premium, the purpose of it is to defray medical costs when you need them. Until such time, we'll still sit with the problem of the between 25 and 23 or 28 billion that gets lost through fraud, waste, and abuse. Coming back to the Health Forensic Management Unit, the unit was established in 2003. It's a unit that was established by member schemes and administrators and managed care organization within who were members of the Board of Healthcare Funders. The need arose from the realization that healthcare fraud was becoming healthcare fraud, waste and abuse was becoming a big issue. Not only in South Africa, I mean, if you read the journals elsewhere, in member states that we do business with, you'll realize that it's not unique to South Africa. It's all over the place for the same reasons of entitlement and grudge purchase. In my submission in Annex 1, it gives the names and the companies that are involved in the unit that is formed, the HFMU. It stands as all the participants that are active in 2019. They are all listed under the Annex A. The main core purpose and the objective of this particular unit was to come up with a unified approach in combating fraud, waste, abuse in the healthcare space or environment. What happens is almost all the member schemes and administrators, I mean, they've got their own forensic units that do the operations from their respective spaces. HFMU doesn't conduct any investigations. It's just a forum where different administrators and medical schemes come together to share their experiences in terms of what they pick up when they do their analytics, their respective analytics. It is important to also realize that you cannot fight the scourge of this fraud, waste, and abuse in silos. You need to collaborate and work together in order to see the exact picture of what is happening. Because, I mean, experience has shown us that people submit claims differently to different medical schemes because of their experience of knowing that this scheme is very active when it comes to, the analytics tools that they use are more effective than the others. So you'll get a different experience when we meet and collaborate on what is picked up on the ground. So this the unit itself consists of a working group that deals with the operations, the operations from different member schemes, as well as the STEERCO, the steering committee, that function as an advisory to make sure that, all member, participants behave in a certain way that is acceptable. I've got Annex B, where I've given the panel the code of conduct expected from the participants. If you agree or you're happy as an organization or as a medical scheme and administrator and managed care about everything else that is expected as a code of conduct or ethics, that if, I want to belong in this organization, this is how I should handle myself or, treat the data and information in that particular way. You then sign and become a member. Those people, that Annex A, all the organizations that are listed there have signed to this code of conduct that makes sure that we use a standard, a standardized format. No one goes out and does his own thing in his corner whilst claiming to belong to this particular unit. And then we also, in our operations, there's a portal, a BHF portal where the data is all shared. Everyone brings the data. We believe in I normally call it, you bring and buy. for you to participate, you must also, bring share your information with us in order for us to share your information with. So it's a collaborative, a united way of sharing information to look at.
Is this your view as well, that there's no racial profiling? Just
Very
like
much so.
PHF? All right.
Very much so, Chairperson.
I was asked this morning, why is it only black doctors are complaining? What is your answer to that?
I look at the demographics. Most of our colleagues. I'm an ex-practicing doctor myself. Most of if you look at the distribution of our colleagues, there's more doctors. There's more black doctors, Indian doctors than any other race.
So there's what? There's more what?
There's more black.
There's more black doctors
in the townships. Where most of the member schemes that are represented here belong. I can share with you as well that recently I attended a talk from the Health Professions Council, where they gave their statistics. It was not a surprise to me that in their own experience they get more, white complaints. Complaints from white doctors by patients more than black. But in my own view, I take it that maybe it's because some racist or racial groupings, they know their rights more than the others. Maybe that's where that experience comes from.
So just to take you back to this specific one, why do we have more complaints from black medical practitioners against medical schemes? You say that is because of the black distribution of doctors in the townships.
That's my own experience. I might be wrong. I can't put my head on the block. It's just a thought that comes to mind when I think about why should it be, because I'm as black as they come. And for me to be, profiling people on race, that will be injustice to me.
The complaint is not that you are profiling people on race, it's that the schemes are profiling people on race. Now, why is it relevant that there are more black doctors in the townships to the question of racial profiling?
I wouldn't really, like I say, I don't have an answer to that as to why that assertion comes about. Because in my own space, when I deal with profiling doctors, I don't look at the race. I look at the practice number. The practice number is the one that it comes forward first, before I get to know that this Dr. Jones is actually black, is not white. So to me, race issue, I don't know where it comes from. I've never experienced it. I don't practice it. And that's fact.
Yeah, no, I understand that. But your answer, I'm trying to get you to explain what is the relationship between the distribution of black doctors in the townships and racial profiling. Why did you give that answer?
It's because my thinking is they tend to see more of people that belong to medical schemes. Black people are more in the majority in South Africa. So obviously the more consultations will be from them. That's my own maybe thinking with my little knowledge of issues.
Are you saying that there are more black members of medical schemes than white?
I tend to believe so, because if you look at the sizes of the townships, obviously there's more people in the townships than in the suburbs, and most of these people, of late, I'm talking of late, yes, in the 2000s and later, they happen to belong to medical schemes. They have they pay premium to belong to medical schemes.
All right, thank you.
May I just take you to your submission to try and understand a bit more how you work?
Yes.
So I can see that the HFMU was established in August 2003, so you've been around for a while.
Yes.
And I can see your membership in your submission as well.
Yes.
And I mean, I can see that a lot of schemes that are allegations have been made against are in the HMU.
HFMU, yes.
Sorry, HFMU. And also there seem to be other members like forensic service providers and non-schemes and non-administrators.
Yes.
Okay.
You do have members. Like I said, my Annexure A, I mean, has got a list of everyone that is a member of HFMU.
Yeah, and there also seem to be provider organizations like ISOLESO, and I presume Preferred Provider Negotiators is also a provider organization.
Yes.
Okay, so
Yes.
it's quite a diverse mix.
Yes.
And I understand also that you distribute these reports to your members, and you've included a redacted copy of such a report. It's item 4, I think, that I'm interested in the reports, which is entitled Investigations.
Yeah, what I'm going to do, Chair, I'm covering the aspects that I'm covering, that particular one of the portal. My colleague will deal with that, will expand on that particular one.
Okay, may I just ask the question, then you can decide between you who's best placed to answer it.
Okay.
The report's currently redacted, but it looks like you name the actual providers when you share the information.
Yes.
Okay, so
Yes.
you will have a name and a surname. We're
Yes.
yet to tell if anyone will indicate whether that you can determine race by virtue of a surname. But you'll name the provider, and then all your membership will get a copy of this provider who's been investigated for fraud, waste, and abuse.
That's the purpose of the unit. It's,
Yeah.
I mean, it's a collective. That's when I gave you the objective of the unit. It's a unified approach,
Yes, no, I
which
mean,
involves everyone involved in the unit itself.
and I presume what I'm summarizing is uncontroversial, so and just fact.
Yeah.
So my question then is, so you do name the providers. So then there's this network that has the names of providers across the network who are being investigated. Now, what does the network do with it? Do they treat that as a red flag and then investigate themselves?
Yes. What happens is, when we share the information, like when Scheme A brings something that they've picked up with a certain provider, they just give a practice number to say, this practice number we've found 1, 2, 3. Please go and check for yourself. I think I've said it in my submission. It's totally unacceptable for any of the participants to come into the unit or into the meeting, get a practice number, and just flag a person just from having had his or her name or a practice number in the meeting.
Sure.
What that means is you must go back to your forensic unit and do your own investigation on that particular practice.
Sure. And from what I understand from the report, and again, please correct me if I'm wrong, it's an investigation is it the results of the investigation or the fact of the investigation that you are sharing with others?
It's an experience of a participant about that particular practice. If I've picked up that, I'm receiving hotlines or about this practice, where members themselves are claiming that they've received remittance advices from the scheme and they don't know that particular doctor. So, a participant will come and say, we've received these allegations. Please go and check if that's the experience you also, getting out there. And if you look at the undertakings that one goes through to belong to this unit, it's a whole list. You can see if you don't agree to any of these undertakings, then you don't belong.
Sure.
There's lots of confidentiality and respect for.
Sure. I'm just interested to understand how this works in practice. So just to go back to this question, when you share the information about the investigations, you've given us examples where one investigation experience says, we identified 59 days based on the above-mentioned assumptions, whereby the service provider exceeded the available consulting hours. So is that a finding, or is that an investigation? That's what I'm trying to understand. Is that a recordal of an investigation, or is it a finding? That's the first question.
It's a trend.
trend.
It's a trend. But let me just give a perspective to this. So, when I make an example, then you understand. There are disciplines where procedure codes are time-based. That when you use this particular code, you must have consulted with that person for an hour.
Sure, I don't want to interrupt you because I'm not intending to be rude in any way. I want to be fair to you and I'll tell you why I'm also asking the question.
Yes.
My concern is, are you worried about a snowballing effect and the accuracy of what is in this list? Because the concern would be that if the experience or the trend described here is then treated by your members as a reason to investigate people, then it snowballs. If you see what I'm saying, because those providers are then flagged as potentially problematic by your full membership. Am I misunderstanding?
No, you're misunderstanding because, the purpose of that flagging doesn't mean, it doesn't give anyone authority to go and flag. You must do your own investigation yourself. It's only after you've done your own investigation where you can take a decision.
Do you know how your members use this information? I think that's probably the better question.
No, I wouldn't really say I know everything that they do with it.
Okay.
It's just, it's just an alarm to say, guys, it's a flag,
Sure.
Watch.
Yeah. There are two ways in which you can approach it. The one is what you are doing, which is red flags. Guys, everyone must be aware. The other is that I've investigated him and found him guilty. Therefore, you must know about him. What is the point of red flagging someone who has not been found guilty?
I think, that's the beginning of.
Yes, but
that's the beginning of how we do things. You flag a person, then you go and do the analysis.
What's the point of telling everyone else? Because you yourself are not sure.
Yeah, but to me, or for the industry, that's how we understand collaboration to mean.
No, you can collaborate after you found me guilty and tell me that I'm a problem because you've satisfied yourself that I'm a problem.
From the beginning, no one is said to. We don't make any allegations.
Yes, but
the flagging doesn't mean somebody is guilty.
But the fact
it just means, please go and check. Go check your statistics and see if my experience is the same as yours.
But what's the point of doing that? What are you saying to them about that person?
Yeah, Chair, can I come in, please?
Well, if Dr. Nhlapo is finished, you may.
No, I just wanted to respond to that part. I think what each scheme and each individual administrator see is only a portion of their data. So it's difficult for them to make any conclusions or to easily come up to finality to say this person is guilty, like you are saying. So the point of flagging is trying to have a better view of the practice, the provider, how he practices throughout the whole day. Because it's very difficult. He can say, I have claimed 4 hours from your from my administration environment, yet there are other administrators there. So the way the portal works, it has various forms. There are actually questions which can be asked of a provider, but the reason for flagging is you only have access or a small view of what's happening because of the data set you have available to yourself. If you could see what's happening all around, it would be easier to come up with the conclusion and then get to that point.
I take your point in relation to.
Put your microphone on.
I'm trying to understand your point, actually, and I'll speak out loud as I do so. The difficulty with, I suppose, the thing I am concerned about in sharing information in this way is that some schemes have big data, have their own big data, and they can use their algorithms to flag practitioners almost blindly using whatever factors they put into the algorithm or are put into the algorithm. So that's relatively neutral, assuming none of the factors are race-based. But where you are naming providers and the experience of them or the trends, that then involves some human intervention and cross-checking. And I'm just not sure that's as neutral in terms of how it's used as an algorithm, running on a large piece of data. That's the concern. Because I'm worried that real people will look at this and make assumptions around guilt in relation to it, even though there's not a finding of guilt there.
So I think what is very important in our environment is getting to a point of guilt is so difficult. I think in the last presentation, you will see that when Connie gives a presentation, and the difficulty is, you saw the stakeholder map, it's very complex. There are many players, and the funder is a third party who comes in to pay and having only seen a small section. So even in our environment, when we see a flag, we know it does not really mean much until you've gone on to investigate. So the participation agreement is very specific to say you cannot go on and act. And even the users, they know it. When you see what we call an outlier, it does not mean anything. All it means is you need to understand what's going on with the practice, because getting to a point of guilt in our environment is very difficult.
Now, you see the problem, I think that's what we're trying to understand clearly about the use of this data with names and surnames of people. I know that your view is that names and surnames tell you nothing about race, but we can debate that later. But the point of it is that the name is now out and the person has been flagged. What schemes do, from what we've been told, I mean, they are still going to come and explain, is that on that basis of information, they can trigger an investigation. And once an investigation is triggered, one of the preliminary steps is to block or put someone on direct payment. So it's not as if the information is neutral information that cannot be used. It's information that can, in fact, be used, even as a trigger for an inquiry into a person's practice.
I think we are missing each other. From what you've just said right now, I think that would be the whole point. The only thing is when you get the information, it does not mean that you have to go and investigate. First thing is, does it affect you? Is the provider claiming in your environment or not? Are you seeing the same trend? In some cases where we have been speaking to schemes, they actually say, no, this provider and this trend is not affecting us. It's not a concern to us. So it's quite a process for someone to actually end up being investigated. Being flagged on its own, it doesn't even give you any basis to go and investigate, because if I was a scheme and I see that someone has been flagged, I cannot take that to the provider and say, you were flagged by that scheme, so I want to start investigating you. It does not really work. There's no basis for anyone to do that.
But this is the point. Dr. Ngcukaitobi says they have no control over what the participants do with the information.
So they would have no basis, because if the provider is not claiming from that scheme, for instance, the fact that is flagged somewhere else, it does not give you any basis of investigation. What will you go to the provider and say, you have done in my environment, or you can accuse him of anything? It is up to the scheme to check the trends that are being flagged and verify if the same is happening in their environment, and then make a decision as to what to do. It's not like a flag is an automatic thing for everyone to start an investigation.
Can I probe this from a different angle, and that's from your standard operating procedure document? Maybe we can understand it through that prism. The first thing I would like to understand, in case I have misunderstood, is HFMU is a collaborative effort. It's a place in which there's information sharing, in which patterns and trends are picked up, and that permits all of the participants to refine their own processes of investigations. Am I right on that? So schemes and administrators, the individual schemes and administrators, have their own investigative processes. It's not the HFMU that does it. It's just an information sharing platform, the HFMU. Okay. So there's a standard operating procedure that you have, right? And in your standard operating procedure under 3.1, you talk about the grounds for an investigation. And you say before an investigation is started, it is necessary to ensure that the investigation is reasonable. This is to ensure that innocent individuals are not investigated. Can you explain to me how that would take place? How would you establish reasonable grounds? And how would you know that whether someone's innocent or not until you have conducted an investigation? I have several follow-up questions, so yeah.
Chair, thank you. I think my colleagues are all looking at me once you touch the investigation field. On a lighter note, trusting a blonde, I'm not so sure whether that was the best decision. But if I may, Chair, so I think what the problem is here is in terms of that the standard operating procedure was a recommended process that we developed over the years to our participants, so that we have had many complaints before in terms of illegal probing, illegal entrapments. We've seen the news, been there, done that. So we've actually required and identified the need to develop a process that it's not a enforceable process. It's a recommendable process to our participants.
Sure. I want you to continue. I don't want to cut you short. I just want to ask, in relation to your point of probes, are you saying that there has been illegal probing and entrapment?
Allegations, Chair. So, I mean, I'm coming from, sorry, I need to say this, probably from a South African police background as well as an NPA background, and 20 years experience and 11 years now in the healthcare environment. So definitely there were allegations. If there's any happening now, I hope and pray they're not part of the HFMU division, because it is not allowed in terms of the SLA, the agreements that we have signed now and developed, and that is not recommended to our participants. So it is illegal for any HFMU participants to adapt any illegal processes like illegal probings and or entrapments. And I think you will appreciate the word probing and entrapment is actually a criminal process in terms of the Section 252As. So obviously, you know, we would not encounter in that processes and procedures, and we would require our participants to be compliant to all legislation.
And you say the participants of HFMU sign a service level agreement with HFMU in which all of this is set out.
They do, Chair.
Have you provided us with the service level agreement?
It is part of our submission, yes.
Okay, so now I understand that, and I understand the standard operating procedures are a guideline for your participants. But what I want to know is, so if this is the guideline, what happens if they don't follow this guideline?
Can you also explain what you do with people who've done illegal entrapment? We've had lots of complaints yesterday about people who were entrapped and illegal probes, people posing as patients, but it turns out that they were probes.
I think we've never received any complaint of that nature from a service provider or anyone towards or to an HFMU member. If that happens, I think we won't take it very lightly. We can even fire that person. We can fire that organization because we don't want to be tainted. The reason why we went out there to draw up this standard process and ethics and conduct was for that reason. To say if you want to belong here, you sign here, you belong, you live by the Bible that we all live by. And I mean, I think PHF has gone, to an extent of making sure that all these guidelines that are here are within law. That it has been tested by the independent legal firm to make sure that all the things that we're saying here can stand legally.
Thanks. I presume that if you do come across those allegations here, you would investigate them
Yes.
if it's in relation to one of
Without
your
doubt.
participants.
Without doubt.
In 3.2 of your standard operating procedure, it states that the investigation must be conducted in as short a period of time as possible, especially in cases where payment is suspended. So these guidelines anticipate a scenario where payment is suspended to a service provider whilst an investigation is ongoing. What do you understand by this phrase you use, payment has been suspended? Do you understand it to mean that the health service provider is no longer receiving direct payment and that payment is being made to the members rather? Or do you understand it as payment is suspended, meaning it's blocked, that service provider is blocked? How should we understand that phrase in your guidelines?
You know, I mean, I think to the panel, let's go back to the CMS's earlier, submission. The payment, I'll tell you of what my thinking and my sharing with my colleagues within the HFMU is. When it comes to paying the service, paying the provider or the member within 30 days. If there's a reason from the funder to believe that all is not well with the behavior of the practice, it doesn't mean payment mustn't be done. The payment must be done to the member. But in the main, what we've experienced is that providers are the ones that come and say, please, go through with the investigation, don't pay the member, wait for the investigation, just do your investigation expediently so that we can sort it out. That's the request that comes from them. Because once you pay the member, the next stop is pick and pay. They'll never come to the doctor to pay.
So when you use in your document suspension of payment, you are talking about suspension of payment to either the provider or the member.
Yes.
I think can I just say, one of the elements, I can't remember the section, that I think it is still 59, I don't remember which subsection. You are supposed to pay within 30 days, but if you find anything untoward, you can then have a period of 60 days while you are investigating, but after having notified a member and the provider.
And the doctor.
So in that space, that could also qualify as suspension of payment.
So that would be an application of Regulation 6. That would be regulation, that's where you get that from, right? So it's your understanding that Section 59.3 is to be read with Regulation 6. Is that right?
Chair, I would like to explain a little bit more in detail if I'm allowed to. So we do come from the governance requirements in terms of where you identify any risk exposure to any fraudulent or waste and or abuse claims where the medical schemes are then required to mitigate that risk. Part of the analysis, the data analysis, and we're going to touch on the investigation side thereof, part of the data analysis, so we find two processes when you conduct the data analysis where this information comes to your knowledge. So either claims have already been paid, where we then only have Section 59.3 to recover whatever funds we then identified to be fraudulent, and some of those claims are in process of being paid. So obviously, to manage our risk exposure, we would place a hold on that claims, but then that is where Regulation 6 would come into, as we are obliged by law to pay within 30 days. So Regulation 6 would require us then to serve a notice to our service providers and our members and require them and inform them what we are busy with, what we found, and give them the opportunity to explain, to respond. And then I think that is where Dr. Mutudi then mentioned, then we have another 60 days period for them to respond and for us to finalize our investigation, and then to release and pay, and or to take them on whatever punitive measure the medical schemes or the administrators have in terms of then their forensic findings. So I think you can combine both Regulation 59.3 in terms of claims already paid versus Regulation 6, Section 59.3 versus Regulation 6, which requires then claims that's still due to be paid. I mean, there's no ways that a scheme may release and pay claims if they have a suspicion that there's fraudulent waste and or abuse claims. I think that would be gross negligence or from their perspective. So I would like to explain then that process in terms of how we then place claims on hold. Blocked, Madam Chair, so you used the word blocked. I know of experience and of information.
Sorry to interrupt. When you say we, I'm just getting kind of confused here because.
Chair, from HFMU perspective. So
but you aren't a medical scheme or administrator?
HFMU, so from reports that we receive. So I'm with HFMU since 2008.
Sorry, but you're describing the Section 59 and Regulation 6. I don't understand HFMU to be implementing those sections.
No, not implementing. So the standard operating procedure was drafted based on that information obtained.
Thank you.
All right, let's move on. I think, Dr. Nhlapo, do you still have points to make? And then if you do,
no, I think I was going straight to my Annexure C on the portal.
Thank you, Chair. I'm going to give you a brief summary of how the portal works. I think we've already described it. So there are several features in terms of the information. I'll start with the data analytics. When a funder tries to detect fraud, they look at their claims data, and this links into what we presented earlier around the coding. Some codes have to be consistent with the ICD-10 code has to be consistent with the procedure codes. Some procedures are impossible on males, and some procedures are impossible on young children, for instance. So schemes can actually deploy some analytics. They can do some trend analysis. There are some providers who suddenly become busy on one specific day of the week, for instance. That would just be an outlier. It's unusual behavior. And then using that information, they start asking questions, why is this happening, and so on. But it does not really mean that they've started a full-on investigation. It's just understanding the trends that the data is showing you. Then there is an element of data sharing, where you actually share simple data across multiple funders. Large administrators can combine data from several schemes and pick up wider trends, as opposed to smaller schemes where they do not have a big data set. So, like you were mentioning, with a bigger data set, your capacity to identify fraud or outliers increases. But as long as you don't have a full data set, you are always limited in terms of what you can pick up. If a provider is out to defraud schemes, you can actually design and do false claims in a way that you know all the funders will not pick you up. I'll just do enough to make sure that this administrator will not identify me as an outlier. So it's important to share data so that funders are able to pick up all these trends across various claims submitted by almost all industry participants. My next slide actually talks to the type of information which is sent on HFMU. So there are generally three categories. There is one where funders share information on completed cases, where they have conducted a full-on investigation and they've come up to a conclusion. They can share the information with other funders so that as they are processing their claims, if the same way of defrauding scheme starts happening in their environment, they're able to pick it up proactively so that at least you don't have to exhaust resources doing the same investigation from all schemes every time. That is the whole point. And then there is notifications where funders may pick up some trends which are funny, maybe abusive, not necessarily fraud, where they can verify with other funders, is this what is happening in your environment? Has anyone ever investigated this and actually come up with an explanation of what's happening? And then the other one, it's where they can ask each other questions. I think we had one case where one funder asked whether a certain beneficiary was registered on any other scheme because there was some missing information. So the way the portal works, it's almost a platform where funders are able to help each other in terms of fraud, waste, and abuse, and it takes away the duplication of effort. It would be very costly for the industry to try and do all this detection and analysis at each funder. So the portal actually aids that part. Then we did talk a bit about the legal opinions. BHF went to length to try and look at whether yes.
Just to match what you're saying in your slide presentation, if you wouldn't mind going to the previous slide, I just want to match what you're saying with the documents we have before us. So you've provided us with alert email. And we've chatted about it already, but it only seems to provide sections called investigation and notifications.
Yeah.
So am I correct, this alert goes out with just the notifications, in other words, just information to other funders on the trends, and investigations, which is something different, which is about the investigations currently being undergone by your members that is being shared. Is that right?
So there are two types of reports that are sent out to members. So an alert, it just is there to notify all participants that there is some new activity on the portal, and then there is regular reports which are more comprehensive. So what you have is an alert. It just means, what it tells me is it was generated after some new information was loaded on the portal.
And so we don't have a copy of the regular reports which are sent out. Is that correct?
No, we didn't get them.
Okay. I'm told it's not.
We can.
It's not
can
been
send it.
submitted, but we can submit one.
Thank you very much. We'll
Yeah.
follow up on that.
So some of the legal opinions that we have got relate to competition law, and the question is the sharing of such information anti-competitive? And the legal opinion that we did receive was it's fine, especially because it's open for everyone to participate, and what you are trying to do is actually in the interest of promoting efficiency in the industry. And then in terms of protection of personal information, this relates to the provider information because that is what is mostly shared. We also got an opinion that the way we have structured the HFMU and how it works, it's also fine from that standpoint of view. And these ones can be provided if required. Then Dr. Clearly mentioned a lot about the participation agreement. So it's not a loose environment where people just come and they can irresponsibly use the information. We are very strict on how people use the information on the portal, as explained earlier on. So I won't spend much time on the slide, just to add that there are some schemes which do provide data. We've also signed an NDA in relation to how that data is used on the portal. I'll talk more into that. So the portal is deployed in two phases. The first phase is just sharing of information. So this is the information which I did discuss. And what the portal ends up looking like, it becomes a library because there are so many notifications about several cases that are loaded with details as to what is happening with specific providers. So it makes it a bit difficult to use for our members, hence the genesis of phase 2. And phase 2 seeks to be also more proactive in that it tries to identify trends, not when someone has really picked up something wrong, because it has got a data analytics element, and it's also linked to phase 1. I'll take you through the data that I'm talking about. So this data, it relates to the specific activity of each provider on a single day. And the whole idea from getting this data is seeing how busy providers are in a single day from a more consolidated data set, rather than looking at data which sits in one administration platform or one small scheme, for instance. So this is the way we explain it. When a scheme looks at its own view, it only sees a tip of the iceberg. So they can do so much analysis, but it's based on a very small data set. When you combine it, you're able to see the whole iceberg. So when you pick up your outliers, it's more accurate and it's more informed from the data sharing. And this data sharing, it's linked to the cases which are loaded, just to help someone using the portal to see what is relevant to me and what is not relevant, because providers do not claim from all 79 schemes. They claim from certain schemes, maybe because of location of the provider and where the members are. So the notifications and the cases which are loaded, all of them do not relate to all funders. There are some which are specific to certain schemes. So the sharing of data also enables the funders to identify what we call the network analysis, where we are able to pick up beneficiaries who are actually working in cohorts with fraudulent providers, which is a bit useful because it's difficult to pick it up from a small data set if that is happening. But when you have a bigger data set, it makes it easier for schemes to pick this up, and when they do their investigations, they're a bit more pointed. So going back to the point which you've raised earlier, it's not about us doing the investigations, but it's just facilitating that process to say if there are any red flags, it should be raised, at least with a bit of more science, much larger data set, so that the investigators can go and put their efforts where they are more relevant. So there are reports which are provided, which we have mentioned, and these reports provide almost a summary of what has been happening, and they are tailored to each specific scheme, so that they know where their highest risk lies and where to place more efforts when it comes to the investigations, especially for the forensic unit. I think my presentation is done. I'll have to hand over to Connie.
Thank you. Can you just tell me, this there's something called a fraud alert. Now it's a HFMU alert report, fraud, waste, and abuse. Is this what, I mean, it contains both notifications and investigations. Would it be a typical alert? It would be in exactly this format. It's Annex C.
Yes, that's correct.
All right. I mean, this is what I would receive as a participant to the portal.
Yes.
All right. Thank you. What's the position now, Dr. Ndlovu? Who's next?
Connie is the next.
All right.
And the last.
Ms. Bacchus.
Chair, thank you. Yes, this is the most difficult part. And maybe just to inform the panel that this is a very high-level processes that the HFMU has actually developed, and that form part of our standard operating procedure. So what we will present to you now is more of our experience coming through all these years in the HFMU and receiving all the reports and the facts that we receive And then just also to inform the panel a little bit more in terms of how the processes, the investigation processes, are being managed within the healthcare industry. So then I'm going to start off with what we then call the preliminary analysis process. And then obviously the data analysis reports is a preventative measure. So we have various prevention strategies that form part of your governance procedures. Obviously you would know that the medical schemes, as any other company in South Africa, are governed by legislation to manage fraud, anti-fraud and corruption policies, processes, and prevention is part thereof. As a prevention strategy, then we developed this data analytics reports. It's a fact throughout the years that where a scheme would be defrauded by a service provider, where we would then place that provider on hold and investigate the provider. Obviously, that provider makes his bread and butter from the fraudulent activity, and then he would move on to other schemes. And we found as the processes that the other participants then would be hammered in terms of fraud, waste, and abuse if we do not share this information. So the sharing of information was actually also a prerogative or a strategy that came from SABRIC, the banking industry, where they have their data portals, where they share their banking accounts, identity theft accounts, and information like that. So within the healthcare industry, we identified this need to create this data portal then, where we share this information so that where some of our schemes identify the fraudsters, it's a fact that it's, that they would move on. We call it actually migrate to other medical schemes and defraud those medical schemes.
How is the perpetrator identified?
Chair, so obviously through various processes. So we've got the data analysis processes where the medical schemes, especially the bigger medical schemes and all the administrators, actually purchase software. We call it the healthcare claims data analysis software that we have, very expensive software and that we purchase and use for data analytics, and it would actually compare service providers against their peers. It would compare providers geographically. It would compare providers within the same disciplines. And then these softwares would actually, as Shelton has identified, or informed the meeting, that they would identify your high-risk claimers. And from your high-risk claimers, that is where we would then conduct a preliminary investigation.
And how is that software populated? I mean, presumably, if you say that it will produce comparison on a geographic same discipline, so it is populated by some data.
It is, Chair. So obviously it's the claims data of the medical schemes. Shelton already also explained that where you analyze the claims data of one scheme, you can only see the claims of a provider from within one scheme. If you combine the claims data of 15 medical schemes, you can actually see the modus operandi, the conduct of that provider over 15 schemes. And then obviously it would identify the very high-risk claimers through that processes. I hope and pray that our medical schemes and all their administrators will bring specific cases to this investigation panel, so that you can actually see that exactly examples of their profiling reports, which is very interesting for you to see. Thank you, Chair.
Who can give us those?
Sorry, Chair.
Well, you say we should ask the schemes. I thought it's one of your...
They are, Chair, but we haven't prepared any examples. So as of the HFMU, I think we would overstepping our boundaries. So, so we would rather give it to our participants to provide such reports to the panel. I think it would be also better to hear these reports firsthand than secondary information coming from us. Chair, thank you. Then the preliminary analysis process, you've asked how we identify. So it's either through whistleblowing hotlines, through This analysis methods that we have, the data analysis software is a very mathematical process where it actually compares values and claims, and the amount of hours. Dr. Clearly also referred to the hours available per day on a service providers, and then combining all the schemes information, you can actually see how many hours this provider is claiming for. Some of these providers would actually render, 48 hours of services in a 24-hour day, which is really impossible. So you would see the trends from all of these data analysis processes that we have, and it is all forming then of how we institute this investigation. So you must remember that claims payments are electronically through EDI system, and we are talking big data, huge data claims that's coming in per day, per provider, per member, per medical scheme, etc. So it's really, claims are paid within 30 days. So we pay claims believing that it is honest and true, and that it's legitimate claims. So, and that is exactly, it's only through these prevention and or identification prevention strategies where we then identify high-risk claims. When and if we identify these high-risk claims, that's the first time where human intervention then actually comes into. So only if and when the high-risk claims are identified. So the human intervention is actually the amount of high-risk claims information that we receive per day, unfortunately does not allow us sufficient time to investigate everything and all that we would like to investigate. So sometimes I realize that, we wish we can extend that 30 days to 60 days, just to give us more time to make sure that the claims that we pay are valid claims. But then within the plenary analysis process, we have data analysts, and they are expert forensic data analysts and paid quite high salaries, wherein they conduct the human intervention that we talk of, and where they then identify or analyze the claims behavior by these high-risk claimers. The data analysts would actually create the findings reports, and the findings reports would identify the erroneous and irregular claiming patterns, Chair, which was referred to initially. So I remember in the 2008-2009 period is only soon thereafter where we developed the definition for fraud, waste and abuse, and previously, and I think with the regulator that drafted the Medical Schemes Act at that stage, the only terms that were used were irregular and or erroneous claims. So I don't think that there should be a discrepancy in terms of what they actually refer to as erroneous, irregular versus fraud, waste and abuse. I think that the regulator, the writer of our legislation actually implied that whenever a claim is invalid, that would form part of irregular and or erroneous claims. And as we have recently defined, it would be part of fraud, waste and abuse. When our data analysts then compile their data analyst reports, they would also establish the monetary value, which is very important for us. I would like to touch the soft, medium and hard cases a little bit later, but then in terms of our punitive measures that we then take thereafter, it would all depend on the monetary value of our cases after a data analysis report has been drafted. Establishing the modus operandi, Chair, you have asked the types of trends and cases that we face, and I've listed a few here. And I do apologize, our training normally is a day long, and I was told that unfortunately you do not have a day for this presentation, but I've quickly listed a couple of the modus operandi matters that we are currently faced with. So first of all, and very known in the field, is the cash and or the groceries that's issued by our service providers. Our members would actually walk in and receive cash, and or they would buy groceries. And whereas the service providers would then put claims to the funders and claim either for consults and or for medicines issued. They would buy groceries at pharmacies and then they would put in claims as if medication was issued. Another modus operandi method that we have is where they would claim for services, but none of that services were actually rendered. And my colleague next to me is actually from the dental discipline, so we would actually find where the providers would place gold into our members' teeth. And obviously we do not pay for gold implants, we only pay for the dental processes. A third modus operandi matter that I've actually identified, or that I would say that is more of a priority trend that we're facing, is duplicate claims where they would merely change a date or they would change a dependent code. It's either the member or the wife or the children's a dependent code, or they would just change the type of service that was provided. So they would maybe claim multiple claims on one person that they actually saw. The fourth trend, please stop me, Chair, if you want some more explanation on this. I'm going to highlight just quickly. It's a trend that we call upcoding. We find that especially where they distribute medication, where they would actually distribute disprints, but would claim comprols from us. So it's what we call upcoding. So they would claim the more expensive product, but then actually just distribute the less value of medication. Chair, the fifth one I need to make mention of, because coming with the NHI, I see this as a huge risk to the whole of South Africa, and this is actually where we are dealing with the boot stock sales. A boot stock is actually referring to a car's boot. So the trend that we see is where the syndicates would actually purchase or buy up expired medication from government hospitals, from pharmacies, whatever. It's expired medication. They would actually repackage it. And redistribute it. Medication is legislated by the Medicines Act, and distribution of some of these medications is legislated, and you need to keep book and records thereof even when you sell this. So this is what we're calling boot stock sales, where they actually then distribute expired medication. I can name a couple of recent investigations that we were informed of on the HFMU floor. We have a recent case of an oculist which sells prosthesis eyes from the boot of his car. So, Chair, you would realize that this is a surgical process and that requires you to go into a theatre to place in a prosthesis eye. So, but the specific person is actually selling prosthesis eyes to members from this boot. Chair, I'm not so sure. There are many examples, but you can just imagine what we are faced out there, and this small number of human intervention investigations, it seems small and insignificant, but the monetary values thereof is very high to medical schemes, and the risk exposure. And then I think that our investigation processes are limited. And I would like to go, if we're finished on this one, maybe to the full investigations and to tell you a little bit about the challenges that we face in the field.
Thank you. This is very illuminating. This is out-and-out fraud within FWA. So as a percentage of all your investigations, what would this out-and-out fraud constitute? And sorry, and the other thing is that I want to just, so, and you made a point about the monetary value. are you saying that while this might be a small percentage of overall FWA, the monetary value of these examples is a lot higher than what is lost through waste and abuse?
I'm going to give you my honest opinion because, and I'm talking from experience in terms of only 11 years in this field. And any statistics provided to this panel, I think would be thumbsuck. Because the statistics that we provide you are actually the statistics identified and comes from historic analysis and or historic experiences. But how do you know whether you are defrauded or not? How do you know how much your fraud exposure is? And how do you know if you close one risk gap or modus operandi trend, how many other trends there are not?
Sure.
So
Now, I'm not asking you to
talking
extrapolate to what, I'm just saying of 100 investigations, how many would there, of that, how many would be of this type? How many would result in findings of this type of fraud?
Yeah, I'm gonna.
You know, it's quite a challenge to give the exact figure, because I mean I can admit that it's a big challenge to quantify the monetary value of fraud in South Africa. You know, considering all the limitations that we have, but maybe I can share with you. I happened to, with Dr. Mtudi, we went to France last year to the European Anti-Fraud conference. I'm just going to read for you so that I don't miss anything. It's just one paragraph. Fraud affects every country and every sector. According to PKF in the United Kingdom, Financial Cost of Health Care Fraud report of 2011. The results collated over 12 years from across the globe show that $415 billion US, that is over 4 trillion is lost through fraud. This would be enough to provide clean, safe water around the globe, bring malaria under control in Africa, provide diphtheria, tetanus, and pertussis vaccine to 23.5 million children under 1 year old who are currently not immunized, quadruple the budget of World Health Organization and the United Nations Children's Fund, with a surplus of over 320 billion. That's how big this is. Yeah. Unfortunately, I'm quoting statistics from countries that have done so much work on the subject than where we are.
Yeah, thanks. I mean, we do have an estimate of 3 to 6% of the entire FWA that is attributable to fraud. So perhaps you could take us through. I just want to understand your modality of how you do an investigation. I think you were going to take us to those steps. Yeah.
Gee, thank you. Gee, thank you.
And just to be clear, not to interrupt, but you're speaking on behalf of kind of your knowledge of the general practice in the industry, particularly your membership, is that right? When you describe these modalities?
Gee, no, it's actually as part of HFMU and the data and information we share.
So HFMU itself is conducting investigations?
No, not conducting investigations, Chair.
This is what I'm asking, sorry.
This is the information that comes through when we collate information. It's not to say we are actively doing investigation. This is what the members bring back to the...
Yeah, the evidence that Ms. Baker is giving, it goes to how investigations are conducted. So I'm just trying to understand where she gets that information from. So is it from what you know of your members conduct investigations?
As I said, Chair, HFMU is made out of medical schemes, administrators, managed care companies. So the representatives that you see here that represent HFMU, except the PHF officials, come from medical schemes, they come from managed care, they come from administrators. So we've got all of us within HFMU, we've got our personal experiences that we can share. This is what she's trying to do now.
Right, thank you. I mean, we can take it, this is the model of how it should be done. And then whether schemes deviate from what, we'll deal with that on the schemes. But I still want you to explain to us how exactly it is done.
Chair.
Can I just come in to explain? So Connie does the trustee training for BHF and WITS on fraud, waste, and abuse. She's also part of HFMU. So we think that some of the information that she shared for the trustee training will be quite relevant for you. So she's speaking from experience of having gone through the investigation process, and
We're
she
not
does this a lot.
questioning that, yeah.
No, I mean, no one says that she's not an expert.
So, no, I'm just explaining why she's here and why she's giving that talk on behalf of HFMU.
All right, thank you very much. That's very helpful. Perhaps we should now get to the heart of the issue.
Thank you, Chair. So it's clear that I'm not the expert.
Yeah, apparently.
Just the information carrier. Chair, thank you very much. So just before I finalize a preliminary analysis, so to us, after we've developed this findings report based on the findings that we have, and remember that's the very first stage, if and when we come to our knowledge that something has taken place. From this findings report, and the best way that I could explain this process followed from here after is to try and explain to the panel that we then divide these matters into soft, medium, and hard matters. And I think the metrics, there's no defined metrics in terms of what is soft and what is medium and what is hard, but I'm going to try and just place it how, and it would differ from scheme to scheme, and I think from administrator to administrator. But then in terms of our standing operating procedures, and as our discussions goes and explanation goes in the HFMU, so what we've defined the soft cases then to be are the first-time offenders or transgressors, not offenders, please don't get my word wrong there. It would be first-time transgressors, small values, human error, administration mistakes. It would really be the very smaller group of involved service providers. Obviously, our response methodologies to this group would be more softer approach, if I then may use that same term. And then we would group the medium transgressors would be maybe a second-time offender, still a small monetary value involved in the audit findings. You know, it would depend on the disciplinary and on the modus operandi that was used. Obviously, we will not accept any fraud as either soft or medium transgressors. Fraud in terms of this country, and I think in each and every scheme, as well as the Medical Schemes Act, has got a zero tolerance for fraud policy. So we would definitely regard fraud then as your hard transgressors, your hard targets. So obviously our response methodologies against your hard targets, which be much more detailed investigations. So, and that then carries me to my next slide in terms of the full-scale investigations. So obviously we cannot be seen to waste time, effort, resources, money on either soft or medium targets as the actual full investigations of your hard targets, your criminal cases, and I'm going to come to the details required even when we go the criminal route. It's to such an extent that it takes a lot of time, a lot of effort, and a lot of resources to actually then go into your full-scale investigations. May I continue?
Yes, please.
Chair, thank you. So obviously, if and when we go into our full-scale investigations, it would be those perpetrators or transgressors that we've identified where we have fraud, clear fraud involved. The data analytical processes are of such nature that they can identify pure fraud from the beginning. And those are the cases that we would then immediately go into our full-scale investigations. And I really hope and pray that our medical schemes and or their administrators will bring some examples to you in terms of such hard reports that they then draft. But Chair, obviously, the full-scale investigations and this, it could involve not just service providers, but also members and or internal personnel. So where you have these full-scale investigations, your investigation methodology that you would then take on would depend on your modus operandi and your involved perpetrators. So obviously, if you have internal personnel involved, we would have, as part of our full-scale investigations, obtain our personnel files, the job descriptions, you know, if there's companies involved, the companies, the registration details. Credit records is important for us because there's a motive behind the conduct of these transgressors. Criminal records also very important to us. You can imagine what process and time it will take to gather this type of information that you require for a full-scale information or investigation. Then, Chair, further processes would then require field investigations. So we have clarified and cleared in our standing operating procedure how, and that's a recommended process, how we would like our HFMU participants to act ethically within the legal requirements, within the criminal processes and procedures. And that standard operating process is exactly drafted for that purposes, where we then prescribe and or recommend what we regard as ethical conduct during these investigations. The physical evidence that we obtain, Chase, I've identified to you the example of this oculist with the prosthesis eyes. So you can realize the need for the patient files, because if he actually provides the services from the boot of his car, how good is his patient files? How good is his administration processes? So there's a reason, a legal reason, why we would want these patient files, why we would want proof of the services delivered, and that for the reason is either to validate the claims, to see whether it's either valid claims or not. Chair, I would like to say that in some cases and instances, we were actually provided with patient files, with proof, and then obviously the matters were closed, and none came from that, because even where the proof has been provided, then no further action is required. It's not everyone that always ends up in the criminal court, so it would depend on whether they cooperate and work with us in terms of to validate the claims. Validation of claims is a governance requirement by the Board of Trustees, which are empowered and escalated then down to its the scheme's management, and obviously then that's the reason why we have forensic investigation firms and or the administrators that does this type of investigations. And it requires an experienced field of skill to investigate healthcare fraud-related matters. I come from that area, I had 20 years of experience, and I need to tell you this, Chair. And I unfortunately walked into the first time in the healthcare environment, and they were talking HPCS, ANCMS, and ICD-10 and nappies, and the language that are used in the healthcare environment is such a closed language that within the SAPS environment and the NPA prosecution environment, it takes quite time for us to explain our matters to our investigators in the SAPS environment and the NPA environment for them to be able to prosecute our cases. The collusion between member and providers actually complicates our investigation extremely, because it's very difficult to prove the non-service provided, especially if they collude together and say that it's actually been provided, and or they confirm the services and or services rendered. So you can imagine how difficult it is for a full investigation to actually be completed and to be ready. So, Chair, I mean, fraud, we all know it's, you need to prove the elements of fraud, the intent. You need to prove intent. You need to prove it's illegal. You need to prove the value of the case, whether it's a potential value, obviously, and or actual value. So actual value would be where claims already paid and losses sustained. Potential values would be where some of those claims which has not yet been paid and we have placed on hold. That would be the potential losses sustained. We have challenges in the criminal registration area in terms of the jurisdictions. Where do we report our cases? So we are referred hence and forth from station to province to station, because where has the fraud actually been committed? By receipt of the administrator, by the scheme, where the scheme's head office is, or where the service provider's practice is. The problem is where the service provider is providing services from the car of his boot. How do you identify the police station where you report your cases? And then we have further challenges in terms of the monetary value of our cases. So you would know that the district court has got a limit of the monetary values versus the regional courts versus the high courts. So, and in terms of the monetary values of our cases, so we had this debate with the NPA for ages in terms of a charge would be a consultation, 350 Rand, 400 Rand, or are we allowed to put all the claims and monetary values together, and can we say, okay, it's 4 million, 5 million, please can we go to the High Court? So we have many challenges in the field of reporting criminal cases, and then up and above these challenges, the skill and experience by our SAPS police investigators are our biggest challenge currently. As the investigation, you would regard that we do data analysis and we do the data analysis reports, but we're not allowed to conduct the investigation on the police behalf. And where you have this, exactly this oculist trend that we face here, further investigation is needed. Maybe cameras, maybe video cameras, definitely maybe a probe or an entrapment, and that would require a Section 252 process through the police for them to understand our healthcare environment. It's very difficult to explain to them, you know, what is requirement in terms of this full investigations. Chair, I'm thinking, I haven't noted everything down. I'm not so sure. We also, I've seen we have polygraphs and fingerprints there. That would be where we have internal personnel involved, access to certain areas which is not allowed. We, a delegation of powers in terms of, we had an internal employee many years ago reported at the HFMU who lifted the holds, who lifted the limits, the benefit limits on a specific benefit for a period for a friend of his to put through his claims. So you can imagine if you lift the benefit and then put the benefit limit back. So it's an IT required process where you need to have all of the IT specialists extracting that information as to who accessed, when the hold was lifted, and when it was placed back. So it is very time consuming to do the full investigation processes. And unfortunately, Dr. Matudi, the successful, because you see that there are successful cases part of the HFM reports as well. And maybe, Chair, if we have had 4 or 5 successful cases in this year, it would be an overstatement. Our cases take extremely long, especially even when it reached the prosecution stage. Postponement after postponement. I think there's nothing new to the challenges.
What's the average of an investigation between the time you start? I mean, there are 2 periods. There's
Yes.
one when you start your own until you've got enough of a case to prosecute it.
Yes.
And then there's the time after the NPA, and then no one knows what happens there. It goes into
Chair, if I may, but May I name 2 cases? But I mean, this is from my own personal experience. We have a current case where the bogus doctors were involved. Our doctor appointed 2 overseas doctors, not registered at all, and they practiced from his rooms. He himself pleaded guilty. Even with the guilty pleadings, it took us 5 years, and we were in Ga court based on the logistic area where his practice was established. And he was sentenced, and part of his sentence is to now testify against the 2 bogus doctors. Unfortunately, he did not adhere to his penalty, and so we rearrested him again.
When was the rearrest?
He was rearrested June, July, and now we're appearing in court again. So, but within that 5 years of case postponements, I closely appeared in Ga court between 20-25 times. So you can imagine, if you take your investigative, your experienced data analysts and the very highly paid people from their daily work to appear at these court proceedings day after day, postponement after postponement, it's huge. Up and above the criminal investigation required from SAPS, we have a matter that was reported in 2013 to SAPS. It's now 2019. The doctor actually provided us with an affidavit of his own where he admits that he paid members cash, 72 members involved, and the investigation to obtain and finalize the chain of evidence. He even provided us with the deposit slips, how he paid these members. So you can imagine it's bank account details, everything that's required to complete the chain of evidence. So since 2013, the investigation has now been finalized, and we're going to go to the NPA only this year. So even the criminal investigations sometimes take 3, 4, 5 years to obtain everything that's required to prove healthcare fraud. It's not as easy as everyone thought. I mean, the commercial crime units are very skilled investigators. Unfortunately, that is where I come from. So when I entered the healthcare environment, it's a different ballgame in terms of what is required, and the process is skill and expertise. Data analytics is not an understandable trend within the criminal and prosecution aspects. So if and when we have data analytics report, we also need to explain to our prosecutors in terms of how did we come to those findings. I'm told that I'm already saying too much, Chair.
All right, thank you. No, I still want your SOP, because what's important about it is that we need to be able to say to schemes that this is the recommended SOP. We want to know if there are variances with it. So, but I think you've submitted it. It's somewhere here.
Yes.
Yes. All right. That's wonderful. So that's the SOP for investigations.
Yes, Chair.
Now, just tell me something. At what point now do schemes suspend membership prior to the completion of the investigation?
Chair, suspend membership?
No, I mean suspend, block a doctor or block a service provider, suspend payments and benefits.
Chair, maybe I should, if I can...
I mean, where does that feature in your SOP?
Yes, Chair, there's a difference between block. There's a difference between place on hold. There's a difference between, and we're getting to the response methodologies in terms of indirect payment, and maybe I should continue with my next slide so that I can explain to the panel in terms of then the response strategies and what we then do in terms of that, because it would explain to then on hold and block. If you would allow me, Chair, thank you. Chair, obviously after conducting our analysis reports and our investigations, then based on whether we have soft, medium or hard targets, the response methodologies would actually then prescribe in what processes the schemes and or the administrators can follow. And again, it would differ from scheme to scheme and or administrator to administrator. So what we would see is the administration action, and that's the acknowledgement of debt. Chair, so we've heard the Council of Medical Schemes stating this morning that there's nothing forbidding medical schemes and or the administrators to have an acknowledgement of debt. In my view, and I think from the HFMU perspective, we regard this as a, and let me just continue, as a contractual commitment, I would say, because it is in writing. It would be a contractual commitment that we would obtain between provider and the medical scheme and or the administrator involved. And the purpose for this acknowledgement of debt, the main purpose for this is to recover the funds. I would like to compare this to the trust account of an attorney. I mean, if any of the trust account funds are stolen, your main purpose is to recover the funds. You can see our challenges that we have in trying to go the criminal route. So then, you know, there's very little other routes that's left for us, so the acknowledgement of debt. Obviously, Chair, we absolutely do not, we're not, how can I say, we don't agree that if they use bully tactics or enforce this process on service providers, that is completely unethical and unacceptable, and the HFMU participants are not allowed to use that bullying tactics and or processes. And in terms of acknowledgement of debt, they can choose whether they want to have the section 59.3, where we just recover then from any future claims, and whether they want acknowledgement of debt. I have seen a contract of an acknowledgement of debt where they even take into consideration the National Credit Act regulations in terms of how much you can afford and whether it's fine with the service provider and affordable by the service provider to pay back the claims. You can imagine if you have 2-3 million rands of a debt owed to a scheme based on whatever behavior that, you know, you can't immediately pay that back. So there must be some sort of an agreement, a contractual agreement between the funder and the service provider.
Chairperson, through you.
Yes.
If I may just add, because before she passes on to the next item. In the main, what I'm talking now, or what I'm sharing with you, it's fact. In the main, what do you see when you get to that administrative action? Is the provider himself or herself coming or asking for a meeting where he brings his legal representative or the association, the representative where he belongs? And it's them who ask for this. It's not the scheme. I've got several cases that I can share with the panel, where it was the lawyer agreeing with the client to say, I've wronged the scheme, I'm prepared to pay. They must just tell me how much. But when it comes out there, it's like people are coerced and forced. I mean, we've got documentary proof that we can share with the panel.
Yeah, well, that will be helpful. I mean, we obviously need to look at the problem from all of its sides.
Yeah, we can
if
share.
you've got those examples, that will be helpful.
Yeah.
Thank you.
I'm thinking too much. Chair, thank you very much. I would like to continue then. Obviously, just I see it is not stated on these slides, but then the difference between block and place on hold. So as have I explained, that even when these service providers come to our attention, you would have claims already paid and or claims in process. claims in process would be placed on hold. And that is where the Regulation 6, the 30 days, then the notice period comes in, and that whole process must take place to our service providers, and it's regulated in terms of that. Blocked claims, Chair, an example, I would like to name a pharmacy many years ago, 2008, 2009. It's actually a non-existent pharmacy. We actually inspected the premises and it's non-existent. Pendulo pharmacy, I don't know if anyone, a Pendulo pharmacy, it's non-existent. So we would block claims completely to that pharmacy. Unfortunately, we already lost a couple of millions between the HFMU participants over a few months, 3-4 months period. And only after we've visited the premises and we have and find no premises that we could block payment to these people. So I would like to differentiate between blocked as non-existent service providers completely, and or identity theft, you would know, is where people steal another person's practice. We have nurses that's not working currently at all, but they've got practice numbers. So we would have health and wellness service providers that would use their practice numbers for illegal claims placed against us. And those are blocked practice numbers. So it's completely illegal, non-existent services provided, and we need to block them, because even if you place them on hold or it doesn't matter, you can't place them on indirect, because then it means they can still claim from the schemes. So that's a clear difference between blocked and placing on hold. So that would be a fraud, waste and abuse response. Chair, then
And how long would you place on hold?
the Regulation 6 only prescribed 30 days. In terms of whether a claim then must be paid, and or if not paid in 30 days, then the notice must be served to that service provider and or the members. In terms of what you've identified and found, and give him then the following 60 days process for him to provide his proof of validation of the claims. So I think it's only allowed to be placed on hold for 30 days, pending then them to validate their claims. Obviously, I can assume, Chair, that if they don't provide the proof, how can you then release and pay? I mean, how can you validate a claim, release and pay, if there was no validation provided to validate the legitimacy of that claim? So I've heard of instances where you now mentioned that they complained that they were placed on hold for extended periods, but then obviously if they've provided and cooperated with the investigators, that wouldn't have required that period to be placed on hold then. Because then somewhere the schemes needs to make a decision as to then what should happen with this provider.
So according to your own SOP, I mean, we understand your relationship. You don't administer this process, but this is designing an SOP.
Yes.
No one should be put on hold for longer than 30 days.
30 days, preferably. And the Regulation 6 says that within that 30 days, they need to inform the provider and or member if there's an investigation. And then that regulation then requires, I think, a 60 days period for them to then communicate and correspond and validate the legitimacy of the claim. So, Chair, I would say then at least within 3 months period, this process needs to be finalized. But now, obviously, if you have a provider that doesn't come to the party, then what do you do then? And I think I'm not speaking on behalf of the schemes, and maybe the schemes and or the administrators can then give you more information as to what they are then supposed to do or what they are doing.
Yes.
So
And on the blocking side, I mean, I understand on the putting someone on hold, 30 days, but at most 90 days for the whole process to be finalized.
That's according to the regulations and the legislation, yes.
You can discuss with the schemes what they actually do in practice.
Yes.
And then on the blocking side, you say that must be in clear-cut cases of fraud,
Definitely.
like a non-existent practice.
Definitely, Chair, but I think the service providers may not know whether they are blocked or placed on hold, and maybe complaints could be that they were actually placed on hold and or they would say that they blocked, but actually only placed on withhold. So I'm not so sure how the message would come to them and how they would know whether they are blocked or placed on hold. So I'm not clear on the communication from the medical schemes and or their forensic stakeholders, how that would be communicated to the service providers.
It may be that sometimes there's a distinction without a difference, because to be placed on indirect payment means that your patients must pay you upfront and then be reimbursed by the scheme. Is that not what it is? So how would the patient get the service then?
Chair, we don't block patients from going to that provider. We place claims payment on hold. So patients can continue to see that provider pending then the investigation. So we don't...
Sure. But what I'm saying is that your definition, the way you explain it is that the provider will not be paid directly. The member will be paid.
No, not in this instance, Chair. So I'm coming to indirect payments, which is different.
Oh, I thought we were talking about indirect payments.
No,
Okay.
no, yeah,
Okay.
no. This is where we conduct the analysis process still and is in process, and then we decide to place on hold to mitigate the risk, and or whether it's clean-cut fraud, we definitely block them so no claims go through. Chair, then we get to the indirect payments. So let me try and explain to you the indirect payments. So obviously, where we have no proof of actual fraud being committed, it's difficult to prove the elements of fraud and or abuse. The only alternative then that we have, not only alternative, one of the response methodologies that we have is to place the service providers on indirect payment. This will break the collusion relationship between member and provider. You can imagine if providers give members cash for services actually not rendered and they would claim from us. These members are actually poor, if I may say so, in need of cash. If you then place the service provider on indirect payment, it's a response strategy to then break the collusion relationship between member and provider, because if you pay the member, which is an obligation from the Medical Schemes Act, that we pay claims and pay members in terms of that. I think it's a choice that we pay by EDI, we pay the providers. So then if you break that relationship between provider and member, the member, if you pay him, he's going to use the money because he needs the money more than the provider, and he's not going to pay the provider, which is a problem to the member and provider, but that is a fraud prevention strategy then for us. And that's the only method, if and when we use the indirect payment, is to break that collusion relationship between provider and member. So we can choose, Chair, either or, indirect payment. We're not enforcing all of these response strategies on the people, so it would depend again, and that's where we come to the soft, medium, and hard targets. The last one that we have there is remove from networks. Chair, you mentioned before and you asked questions about the networks, DSP networks designated.
Sorry. Just on the indirect payment, you say to break the collusion between members and providers. So you would use indirect payment in instances where the abuse or that was at play was of that nature. Would you, as opposed to, for example, using indirect payment as a response to a coding irregularity?
Chair, so from experience, I can't say that just on a coding error you would place the service provider on indirect payment. That's why I say that we do classify them between soft, medium, and hard. It would depend on the transgression, whether you place them on indirect payment. So to me, it won't be just a coding error. And I do think that your investigation report, your analysis report outcomes would prescribe the response strategy that you would follow. I can unfortunately not speak on behalf of medical schemes and or their administrators. I can just speak on behalf of the process that we currently use. Does that answer you?
And then there is the last one, which is the removal from a network.
Yes.
Yeah.
Chair, so obviously that's just another fraud, waste and abuse response strategy. It's mitigating the risk. We obviously do not want to have providers on our networks that's fraudulent and or abusers of our systems and processes. So we then would actually, as part of our fraud prevention and a strategy, mitigation strategy, remove them from our DSP provider networks. Just in terms of a DSP provider network, anyone can apply. It's not just closed. Any provider can apply to be on the DSP networks of any scheme and or administrator and or I don't know who else manage these DSP networks. But then obviously your DSP networks on application would also go through a vetting process. So I know that some of the administrators and or medical schemes and their vetting process is actually performed by BHF themselves, wherein they vet service providers, not DSP service providers, but in terms of if and when they apply to be registered. The PCNS would then assist the schemes and or the administrators where they would allow these providers to be part of their DSP networks. Many of the DSP networks would be informed by information like geographical areas where there's a need of services by your members. It would look at disciplinary logistics in terms of if they're in rural areas, how far are they from a service provider? So many of the DSP providers are actually determined by aspects and or requirements in that it's not just, a nonsensical reason for having a DSP provider network.
Thank you. Do you have another slide to go through?
Chair, that concludes the investigation part of it. Then we look at the monitoring, just to conclude the circle of life in terms of fraud management. The very last stage would be then the monitoring of these fraud, waste and abuse transgressors and or, when you identified a first offender, you must make sure that, it doesn't happen and he doesn't transgress the conduct again, so that he doesn't become a second offender or third offender, and or that he doesn't flow from soft, medium to a hard target. So our monitoring would definitely include then all the reports that we share with each other, the fraud, waste and abuse reports, industry reports. We receive industry reports from the Council of Medical Schemes when they have their investigation outcomes. HPCSA would also place monthly reports on their website in terms of service providers which they found guilty and or suspended, sentences that they've issued. So obviously from this monitoring perspective, we also look at all these reports. The prosecution is also very important in terms of the proof required and for any future cases that we are preparing for. If we made a mistake once, you don't make a mistake a second time. So you need to make sure that you then close any gap or loophole created in a lost matter in a criminal prosecution. So, Chair, there's many ways to monitor progress and successes in this area. And then our fraud, waste and abuse reports are only one method for our, especially the smaller schemes, to make sure it's a prevention strategy and that, they don't lose monies to fraudsters, which are actually identified by the biggest schemes and using this analysis software that we have. Very expensive. I hope our administrator would come and give you the cost regarding the purchase of software like that, because the smaller schemes unfortunately cannot afford it. Absolutely not. Even the biggest schemes it's too expensive. And so we opted for the administrator. So when an administrator would manage 15, 16 medical schemes, they would purchase the software and provide it. In the past, as a key performance indicator, if we have 5% of our claims analyzed for healthcare fraud, waste and abuse, it would be a lot. With the software that we have, we can analyze 100% of the healthcare claims that goes through that software to then be validated and or processed for any high-risk claimants through that data analysis software. Chair, that concludes my presentation. I'm not so sure there's any questions.
Ms. Becker, just one last question from my side. If you are an investigator in a scheme or administrator, and I understand you have been and you have experience of this space, when you receive the HFMU alert or report, what practically do you do with it?
Am I allowed to answer this? I'm just worried that if I'm allowed to answer this question. I am worried because my medical scheme should not be involved. But I'm talking on behalf of administrator and experiences. So obviously you need to analyze your own claims when you receive this information. You are not allowed to act at all. And to red flag or highlight or anything, the words that I heard from the panel before, it's completely unacceptable and unethical to act based on the fraud, waste and abuse reports. You are required first, and that's a service level agreement that we sign with all participants, you are required first to analyze your own data. Based on your own data, you're allowed to act. And then only on your own data, if there are any erroneous or irregular claiming patterns or high-risk trends that you identified, are you then allowed to then put that whole process to start with a preliminary phase, a full investigation phase, and or whatever is required.
What do you look for in your own data?
Sorry?
What do you look for in your own data?
You look for a similar trend and or you look at your claims data for that service provider. So it assists us to cut time short. So if you would look at Dr. Hleli, you would look at the trend would be analyzed. So you mentioned before that it said that what was the trend that we've identified in this previous report, but you would actually look at that code and at that trend within your claims data, and then you would identify whether there's any erroneous or
Yeah, I mean, your point is that they shouldn't slavishly follow what they get from you. They must,
no, definitely
they must
not.
forensically investigate what they get.
Definitely.
It may just be a pointer, but it's a first pointer.
Yes, Chair. They're not allowed to act on our information provided, and that's where Dr. clearly said it's a bring and bribe process, sort of. You bring your own data as well, you know, while you receive this information, but you are not allowed to act based on the data received from the HFMU report. You must investigate and analyze your own claims data first for any erroneous claims or irregularities, and only then, if you do find something, are you allowed to act based on that.
So if for example, this report says Mr. X, the example here is services not rendered, but Mr. X is being investigated for services not rendered, do you go to your claims data and look for Mr. X?
I assume that would cut on time, yes, Chair. It would definitely, I mean, to investigate 5,000 Mr. X's, I mean, if you don't know the practice numbers, then obviously it would assist you to cut short on time to investigate Dr. S's claims, but you're not allowed to act only and even when you find something erroneous and irregular, are you then allowed to act against Mr. X?
I mean, that is the big benefit of the information sharing.
Exactly.
That it gives you the red flag.
Yes.
But from there, you must do your own work.
Own work, yes,
No,
true.
I understand.
Thank you.
All right, thank you. Dr. Mutuli, you brought your colleagues here, so I presume that this is the end of their presentation. All right.
Thank you, Chair.
All right, thank you. Well,
Person, just in closing, it would be injustice to close, especially on the on the HFMU side, without giving you the main principle and objective of the HFMU. In the final analysis, with all what has been said, rehabilitation is one of the main things that we push. We've got, the country needs healthcare providers. We can't be kicking or sending them all to jail. Rehabilitation, if those that are serious about their profession and they want to mend their ways, by all means. So rehabilitation is one of the things that we also are pushing.
thank you very much. All right, well, it remains of me then to thank you for coming and presenting. It's certainly been eye-opening, and we understand the structure better now because of your presentation. You might be called again, and you might be sent letters requesting for further information. So if you don't mind continuing your spirit of cooperation with the panel.
With pleasure.
Today's session is then adjourned. We will reconvene tomorrow at 10 o'clock. Who's coming tomorrow? All right. Anyway, the session is adjourned.